Lauren asked me to speak about my experience with IVIG therapy in refractory autoimmune dysautonomias. I consider myself an autoimmunologist. As far as I know, I think I'm the first person in the world who's done training in multidisciplinary autoimmune disease, which is an idea that was put forward by one of the world leaders in autoimmune disease, Dr. Yehuda Schoenfeld. And a lot of what I do doesn't fit neatly into any of the current academic silos of medicine, and I think probably most of the patients here can relate to that problem. I will discuss the off-label use of IVIG. This slide illustrates the way that I think about autoimmunity and dysautonomia. There's a very interesting emerging link between the autonomic nervous system and the immune system. There are multiple complex pathways that have been described linking autonomic dysfunction and immune dysregulation, and they may drive each other, and this sort of gets to what Dr. Goodman was talking about, and I think very much like he does. At the present time, I think that the red circle plays a more important role, and I'll show you later that more of my patients seem to have autoantibodies that have been described in association with systemic autoimmune disease. But as we heard in the talk before, the muscarinic and adrenergic receptor antibodies, depending upon whether they're shown to be pathogenic and important in these diseases or whether they might be natural antibodies regulating our sympathetic tone, remains to be seen for sure. So the relative size of these two contributors remains unclear right now. But for the antibodies that we have commercially available in the United States, which currently don't include the muscarinic and adrenergic receptor antibodies, the red circle for me has been more important. And I think it's really important for patients and physicians to recognize that dysautonomia may be actually the initial manifestation of systemic autoimmune disease. And I think, again, that gets back to this emerging link between the two systems. I want to take a minute and describe what IVIG is. It is not a medication and it is not a biologic therapy, but rather it's a blood product derived from blood donors, each of whom are screened for various infectious diseases. Their blood is centrifuged, and you can see that allows the plasma or liquid part of the blood to be separated from the blood cells. The immunoglobulins, which are antibodies, are contained in the plasma or liquid part fraction of the blood. And then there is a process which takes up to 9 months whereby they're purified, nanofiltered, and treated to inactivate infectious agents, and stabilizers are added. And that's what we call IVIG, and there are many manufacturers. Each batch is required by the FDA to come from at least 1,000 blood donors, but in reality, they probably can come from up to 50,000 different blood donors in order to provide diversity in the antibody repertoire for patients who are treated with immune deficiency syndromes. IVIG is very unique in its recognized efficacy in treatment of such a broad range of autoimmune diseases. If you look up any autoimmune disease, you can probably find a study where IVIG has been used. And in particular, as is relevant here, like for autoimmune autonomic neuropathy, it has recognized efficacy in peripheral nerve disorders, and Guillain-Barré syndrome, CIDP and MMN are all FDA-approved indications for IVIG that are autoimmune peripheral nerve disorders. The initial case report describing the very successful use of, sorry, that's just on my screen. The very successful use of IVIG in a patient with autonomic dysfunction was published in The Lancet in 1996, and multiple other case reports followed. Then there were several case series, one by Dr. Fox, who's sitting in the front, suggesting efficacy of IVIG or demonstrating efficacy of IVIG in various autonomic disorders that were either suspected or confirmed to be autoimmune, and they reported response rates of 74 to 80%. So IVIG is administered by vein in an infusion center or by a home infusion company. Most often it's given every 2 to 4 weeks, and usually it has to be continued indefinitely for most patients or substituted with something else. The half-life is 3 to 4 weeks. It's important to have any antibody testing that you might need done before you start the treatment, because it can interfere with IgG antibody tests. In particular, there are some that seem to pop up more than others for reasons which are unclear to me. The hepatitis B core antibody is an important one if you ever go on from IVIG to rituximab and you need to be screened for hepatitis B. Then if you have a core antibody, it's probably from your IVIG, and you should have PCR testing. Other ones include GAD65, thyroid antibodies, and again, it's only the IgG antibody tests that will be affected because IVIG is 99% IgG. IVIG is unique among our potent immune modulatory agents in that it's really the only one that provides immune protection and not immune suppression. But it is very expensive and it's burdensome to administer. The infusions take a long time and there can be side effects. IVIG has been around a long time and is not a new drug at all. It was used initially in the early 1950s for immune deficiency, which is the most intuitive use for the drug. Patients who have low antibody levels as a part of a disease process benefit from this drug, and it reduces their risk of infections. There was actually a patient in the earlier days who had immune deficiency but also had autoimmune thrombocytopenia. And the physicians noticed that every time he got IVIG that his platelet counts would come up. And that's what led to people starting to look at IVIG in autoimmune disease. And the first description of the use of IVIG actually in these kids with ITP was in 1981, 30 years later. And because it's not really intuitive that IVIG would be used to treat autoimmune disease. If you already have too much immunity, why would we want to give you more? But actually, it was learned over the years that IVIG has multiple complex effects on the immune system. I could list about 10 different proposed mechanisms, and they may be different in different diseases. All physicians, or most physicians who use IVIG to treat patients with dysautonomia, recognize there's an increased risk of aseptic meningitis in this patient population. It's actually a rare side effect in patients with other autoimmune diseases. The reason for this we don't know, but it's clear that if you give the drug slower and with hydration, usually patients will not develop this. But there are sort of lesser degrees of it, less severe headache and neck pain and flu-like symptoms that are common despite giving it slowly and despite giving hydration. And these symptoms can last a few days post-infusion. There are also important complications that can occur in IVIG, and anybody considering the use of it has to be aware of these. The two most important are probably thrombosis or blood clots in the arteries or the veins, and also toxicity to the kidneys. And I've listed a few other ones. These toxicities are uncommon if you give it slowly and with adequate hydration. And I personally have used a lot of IVIG and have not had a patient have a serious complication, but I expect that one day I will. So the drug is dosed, or the blood product is dosed by weight. And there are two general categories of dosing. Low dose or replacement dose is used for these patients who have low antibody levels or what we call immune deficiency. And we use high dose in autoimmune disease, and the range we use is from 1 gram per kilogram monthly to a maximum of 2 grams per kilogram monthly. I usually start at 1 gram per kilogram monthly, and most of my patients do respond to that on the lower end of the dose range. I do have one patient who needs 2 grams per kilogram per month. Again, I can't emphasize enough the need to give it very slowly with aggressive hydration. I wish I would have known I was going to have more time. I would have shown my protocol, but I start with the gram per kilogram monthly divided into weekly doses. So a quarter of a gram per kilogram given weekly. And I do that for about a month, and if patients are doing well with that, then I give about a 1/3 gram per kilogram every 10 days, and then do that for about a month. And if people are doing well with that, then I'll give a 1/2 gram per kilogram every 2 weeks, and slowly work up to where the goal is to get the whole gram per kilogram monthly all at once. And not all of my patients are able to tolerate that. Some stay at 1/2 gram per kilogram every 2 weeks. For patients who do get headaches, despite giving the medications or the drugs slowly, non-steroidals and antihistamines are helpful in reducing side effects when given in a scheduled basis starting before the morning before the infusion. An occasional patient will need another liter of fluids after. That can be really helpful. But giving the fluids adds another hour or 2 to the infusion, which is already long, and it becomes tempting to want to run the fluids with the IVIG, but that should never be done because it risks precipitating out the immunoglobulin molecules, which can cause loss of efficacy and nephrotoxicity. So, and I don't think that everybody knows that. So if you do ever get IVIG, you want to make sure they're not running the fluids at the same, piggybacking the fluids onto the IVIG. Subcutaneous immunoglobulin is an important option to be aware of because it can lead to fewer side effects for some patients, and it also can be a lot more convenient and does not require venous access. The light blue thing that this patient is holding is a pump, which automatically infuses the drug slowly. And there are, and this patient is infusing at 4 different sites with these butterflies that contain a very, very tiny needle that is about 8 millimeters long. And for most people, it's completely painless to insert those tiny needles. The infusion for most patients takes between 1 and 2 hours. Everything is customized to each individual patient, including the number of sites they choose to infuse. As you can imagine, when you're infusing the drug, it leads to kind of like an outpouching of the IVIG and stretches the tissues and leads to some kind of a little bit of pain. And so some people will choose, I have one patient who infuses at 5 sites so that she only has to infuse once a week. Other people might choose to do 2 or 3 sites twice a week. And it's really customizable for each individual patient. And there's kind of a correction factor based on your IVIG dose that can help determine your dose. And it should be started 1 week after your last IVIG infusion. I do not test all patients for autoimmunity. There are certain factors that might suggest that someone may have that, and I think Dr. Goodman and I have a very similar philosophy. Obviously, if somebody has an underlying autoimmune disease, that's a big clue that their POTS or dysautonomia may be autoimmune. Only about 8% of the population will ever get an autoimmune disease, so if you have a family history of an autoimmune disease, that's giving you by definition a genetic predisposition, and I use that as a very important clue. As Dr. Goodman alluded to, POTS preceded by an environmental trigger is also a really important clue. Somebody who was completely healthy and then had an infection or surgery, vaccination, trauma, concussion, pregnancy, and then gets POTS, it's suspicious for an autoimmune cause, as well as an acute or subacute decline. And a lot of patients are quite severely affected when they have an autoimmune cause. And another clue is just sort of progressive worsening despite the lifestyle and pharmacologic therapies that we usually begin with. And then I've listed some signs and symptoms as well that might suggest a possible autoimmune cause. I want to shift gears and talk about my patients that I've treated with IVIG. Really, the biggest thing for me to consider that option is if somebody is unable to work or attend school on a regular basis. And they obviously must have an autonomic disorder and persistent antibody positivity. I do usually like to repeat antibody tests and show that they're persistently there, although antibodies can wax and wane, and so sometimes you can repeat it and it's negative, but the antibody later will come back, and so it can be a little bit tricky. But for most people, if they have an antibody and you retest them, it'll be there in a few months. I also do a skin biopsy on all my patients I'm considering giving IVIG, and for me it's been very helpful in getting the IVIG approved with insurance companies. On the right, you can see what we call the sweat gland nerve fiber density. These are considered the autonomic nerves. They're the small fiber nerves that go around sweat glands. And the top is from a normal patient or a normal person. That's considered a normal density. There are very complicated mathematical formulas that are used to determine this density. They're actually quite reproducible. And the bottom patient has reduced sweat gland nerve fiber density or autonomic neuropathy. So if a patient has persistent evidence of autoantibodies and autonomic neuropathy on biopsy, which can also be suggested by an abnormal QSART test, and I know Dr. Chamali is talking next. He does both because neither one of these tests is 100% sensitive. But in my patients who are sick enough to be considered for IVIG, I've found most of them do have an abnormal skin biopsy or their nerve fiber density may be very low normal. I'm including only patients that have been treated for 3 months or longer in the data that I'm going to show you, and I did not exclude anybody by age. So I have 34 patients that have gotten IVIG for at least 3 months and met the criteria we just went over, and 82% of them were female. The average age at the start of IVIG was 34.8 years, and the average disease duration was 5.7 years. One patient had been sick for 20 years, and that is my experience that patients with an autoimmune cause who do not get treated with immune therapy, usually they don't recover if they're severely affected. I have seen people improve who are less severely affected, but the people who are really severely affected, they often don't recover unless we treat the underlying cause. A third of them had joint hypermobility syndrome by the old Brighton's criteria, and a lot of patients had significant comorbidities that might influence their response to IVIG. This slide shows the autonomic disorders that we're seeing. 40% had more than one. Most patients had POTS. 20% of patients had what I consider severe GI dysmotility, and I define that as being dependent on feeding artificial nutrition, either by vein or by a feeding tube. But the majority of the other patients had a lesser degree of GI dysmotility. CRPS stands for complex regional pain syndrome. A few patients had also dependency on a bladder catheter. I put this slide in to show the degree of immune dysregulation I see in a lot of these patients. There's not a consistent autoimmune fingerprint, but many have significant abnormalities noted on immune testing. And I think, again, that may get back to this link between the dysautonomias driving immune dysregulation and vice versa that Dr. Goodman talked about. To me, this is the most important slide in my talk. 78% or so of patients had one or more antiphospholipid antibodies, and that's a particular interest of mine that I'm going to spend a few minutes talking about. I'm very interested also in these novel or early Sjogren's antibodies. Lauren actually had a poster last year at the International Autoimmunity meeting in Leipzig, and also at the American Academy of Neurology meeting, in which they found, she and Dr. Gudesblad found these antibodies in 41% of patients with POTS and dry eyes and dry mouth. I don't know if they were as sick as the patients that I'm showing here. But the SSA and SSB antibodies, as Dr. Goodman alluded to this morning, are not very sensitive in picking up the patients with autonomic dysfunction. And neither, in my experience, is the Autoimmune Dysautonomia panel. So I see a lot of patients who've been to people who've heard of the importance of Sjogren's and this Mayo autoimmune panel, and they have had an autoimmune cause, quote unquote, ruled out by having the SSA, SSB, and Autoimmune Dysautonomia panel. And I think these other antibodies are much more important. Antiphospholipid syndrome is actually a common problem, but it's under-recognized, under-thought of, underdiagnosed, but it is estimated to affect 1% of the population. It's a systemic autoimmune clotting disease. It's very different from like factor V Leiden and conditions like that just cause blood clots. It is a systemic autoimmune disease with a lot of other manifestations. The hallmarks that we're all taught about in medical school are blood clots and pregnancy complications, including stillbirth, recurrent miscarriage, and preeclampsia. But there are, as I mentioned, other problems I'll talk about. We first described this link with autonomic disorders almost 4 years ago. There's a characteristic phenotype that we described, and that is what leads me to consider this possibility even in patients who are less severely affected, because I think it's an important diagnosis to make. And in my patients with POTS or other autonomic disorders, if they have Raynaud's phenomenon, especially if it came on with the POTS or later, not present since childhood. Livido-reticularis, which is I'm taking up Lauren's time. She's not going to be back. Yeah, so you're giving me a warning for both? Oh, okay, I was sort of taking my time because I thought. Livido-reticularis is a sort of blotchy skin. Refractory migraine, most people with POTS have headache, but refractory migraine, especially with aura, and prominent memory issues. And there's an important link with Hashimoto's thyroiditis and Sjogren's syndrome. And importantly, in the people with POTS, 60% of my patients have had blood clots. And I think that's why this is a really important diagnosis to make. The antibodies, the upper ones are the ones included in the criteria, which have done a huge disservice, in my opinion, to this disease. Because we're capturing only the tip of the iceberg, and I've included some of the other ones that have been helpful for me in making the diagnosis. And often in the autonomic patients, they're IgM, and they're often low titer. You can see here that the IgM molecule is much larger than the IgG molecule, and that may contribute to the sort of sludging of the blood or microthrombosis that I think is involved in how the autonomic disorders occur, how or why they occur in conjunction with APS. Diabetes is recognized by everybody as a common cause of autonomic neuropathy, and the way in which it actually causes that is by damaging the small blood vessels. And I think that's what happens in APS as well. The antibodies activate the lining cells of the blood vessels, the platelets, and the clotting factors, and we know that kind of sludging or microthrombosis occurs, and this may over time lead to sort of low-level damage of the autonomic nerves, which may in turn lead to dysregulation of the immune system, which may in turn lead to worsening autonomic dysfunction, sort of as Dr. Goodman mentioned. But these antibodies also can bind to nerves and they can alter their function. This is a great video by Dr. Hughes, who first described the syndrome. It's on YouTube. If you type in Hughes syndrome and look for this mother and her baby, if you want to help spread the word of this link to your doctors, because this is not in our medical education yet, but I hope one day it will be. So 88% of my patients responded. I'll show you in a minute that the average time to response is 5.7 weeks, and patients who have had disease for up to 20 years responded. Most patients responded to a fairly low dose. I wasn't able to figure out a way in which the non-responders were different from the responders. This is the Compass 31 in patients who were treated for at least 12 months. This is a standard patient-reported outcome tool used in autonomic disorders. And this is patient-reported health status, where if 100% is normal, these patients, as you can see, started off quite unwell, ranging between 5% and 40% level of functioning per their estimation. And after 12 months of IVIG, there was quite significant improvement. This is one of my patients with severe POTS due to APS, who was in a reclining wheelchair getting 2 liters of IV fluids every 2 weeks for several years, many years. And 3 months on IVIG, she was at Comic-Con without a wheelchair and no longer receiving IV fluids. This shows the time to first sign of improvement, where the patient started to think, maybe this is helping me. Importantly, some people noted improvement quite early, the one patient at 1 week, but a couple patients didn't notice any signs of improvement for 11 or 12 weeks. So I think it's important to get, I usually like to give at least 4 or 5 months before I give up on the therapy. But the kind of full response to IVIG can take quite a long time, and it takes a long time for nerves to regenerate. And this is a patient with hyperadrenergic POTS, and you can see these are the doses of clonidine. She was on massive doses of clonidine, which is a suppressor of the sympathetic nervous system. And it took over 2 years for her to get off that medication, and the other one is Florinef. And this is another patient of mine who's been treated for 2 years, who's still working on getting off his narcotics. He was on massive doses for complex regional pain syndrome and POTS. He wasn't on narcotics for the POTS, but for the complex regional pain syndrome, and you can see a dramatic, gradual drop in his dose requirement. There were no major complications and no patient discontinued therapy for major or minor toxicities, but a lot of patients have kind of nuisance symptoms from IVIG, again, that usually last up to a few days after the infusion. So in conclusion, IVIG is highly efficacious in these very selected patients with refractory autoimmune dysautonomia. I'm not advocating the use of IVIG for most patients with POTS. The time to initial response ranges from 1 to 12 weeks. Full response may take well over 1 or even 2 years. Most patients respond to a dose of less than 1.3 grams per kilogram monthly. Most patients tolerate the treatment well when given slowly with pre and sometimes post-hydration. There is not a unique antibody fingerprint for responding patients, but many of them have, many of them have evidence for widespread immune dysregulation. And the antiphospholipid antibodies and novel Sjogren's antibodies are much more common than the autoimmune dysautonomia panel antibodies or the SSA and SSB. Do I have time for questions or, okay, thank you.